السلام عليكم. It's my pleasure to be present among you today on the 9th International Neonatology Conference of the Ain Shams Society for Neonatal Care and Continuous Medical Education. أنا بهني أستاذ الدكتور هشام عوض والدكتورة صفاء، الدكتورة نهال الرجال، الدكتورة صفاء شفيق، الدكتورة رانيا الفراج، الدكتورة غادة جاد، والدكتورة رانيا اسماعيل، وكل وحدة النيوناتولوجي for a real continuous CME continuous medical education. ان انا شايفه النشاط قوي والمعلومات كل شويه مستمره على مدى كل شويه ميتنج ومعلومات جديده and high interaction. احيي الشير بيرسونز الموجودين على البانل، شرفني ان انا اكون موجوده ما بينكم. and it's my pleasure to present the first speaker, Dr. Omayma Hamida. She is a neonatal consultant of the Scottish Neonatal Network. ودكتورة أميمة بنت عين شمس.
أكيد.
ولما بيقولوا لي دكتورة أميمة قلت لهم أميمة بتاعتنا. So it's my pleasure إن أنا أسمعها وهي بتقدم radiological assessment of lung diseases with introducing lung ultrasound.
Thank you very much, Dr. Alia. First of all, I would like to thank all the attendees for coming today. من كل أنحاء المعمورة، شكرا جزيلا. It's really, I'm really honored to be and pleased to be with you today. شكرا لكل اللي تعب ونظم المؤتمر الرائع ده، دكتورة صفاء شفيق ودكتورة رانيا الفراج ودكتورة غادة جاد وكل التيم ودكتورة رانيا اسماعيل everyone، وطبعا دكتور هشام عوض. ربنا يخليكوا ودايما كده منورنا في كل المؤتمرات ونتعلم منها. Thank you very much everyone. والنهارده انا هتكلم على lung ultrasound و its use and applications in the neonatal unit. Before I start ممكن اسال يعني how many of you use lung ultrasound in the neonatal unit on daily basis? Okay, that's great. أنا متفائلة شوية النهاردة إن أنا متهيألي إنه كل الاتنديز بعد البرزنتيشن أو في آخر البرزنتيشن they will be able إنه to decipher the codes أو تفك شفرة اللنج ultrasound وتقدر الحقيقة to interpret وتقدر تدي decision based على ال findings. So hopefully at the end of the presentation will be all of us able to read lung ultrasound in the newborn babies. There is nothing to disclose. So my objectives today, why lung ultrasounds, how to make the lung ultrasound basics very easy to understand, and how to perform lung ultrasounds, what are the signatures or patterns of lung ultrasound, and the scoring system of lung ultrasound, and what change if you adopt ultrasound on daily basis, what change it can make in your daily practice in the intensive care. Can anybody guess what this or know what's this? هشام هنا قال لي it looks like البتاع بتاعت المطبخ اللي بنعمل بيها الفطير كده. حد قال لي قبل كده ممكن تبقى زي صباع الروج. Any guess? What do you think it looks like? ونرميها في يعني دي this is nice to use it، نحط letter جواها وممكن نرميها رسالة في البحر. nice. So هو في حكاية ورا القصة دي. كان في دكتور شاب فرنساوي سنة 1816 بيتمشى كده في جنينة قصر اللوفر وشاف ولاد صغيرين بيلعبوا مع بعض. exactly. شاف أطفال بيلعبوا مع بعض، واحد فيهم ماسك عصاية خشب والتاني بيشخبط أو بيخرفش عليها كده بمسمار they are very excited إن هم بيسمعوا amplified sounds. نفس الدكتور ده في نفس السنة في 1816 جات له عيانة، كان وقتها كانوا الدكاترة بيحطوا راسهم على صدر العيان ويسمعوا الهارت ويسمعوا الشست. actually what he did, he had a patient, كانت صغيرة في السن. She was a young lady, which was a bit overweight, which has heart problems. So when he tries to listen to her, he felt embarrassed. This decent guy immediately remembered this acoustic phenomena, إنه ممكن يعمل حاجة زي كده. So he brought a piece of paper, he rolled it, we tried to listen to the patient, and he actually heard better. So since then, for 3 years, he started to work on how to invent something to listen with. And this is René Laennec, who invented the first stethoscope. And as you can see, this is like a tube with some, it's a bit hollow here, and this is a patient piece, and this is the earpiece. And this is in 1819. And in 1819, this was one of the historic publications in the history of medicine, l'auscultation médiate, which is like using something intermediate to listen to the patient, because in that era, everybody was just putting their ears on the patients. By the way, there was a resistance to use the stethoscope initially, like anything new. So from the 1819 until now, a lot of progress happened with the stethoscope. And status is a Greek word. Status means chest, and scope means to explore. And usually we perceive scope as something to see with. So in 1963, this was the revolutionary change in the stethoscope by David Letman. He is a cardiologist from University of Harvard who did the stethoscope that we use nowadays. So what are we, all of us use the stethoscope, right? So what are we using the stethoscope for in babies? Used to listen to what? What are the findings? Diminished air entry, crepitations, of course, if secretions, fine. If there is probably an alveolar pathology. Any more data? Nothing much indeed. And then we ask for a chest X-ray, which is a two-dimensional image for a three-dimensional organ. Okay, so what if I tell you now, I'll bring you, all of you, and this is a baby, I'm going to lift the sternum, open the ribs, and let you visualize the lungs live. If it is atelectatic, you can recruit the lung by ventilatory maneuver. If there is pneumothorax, you will see, and you can do immediate intervention. If there is fluid, you will drain it. If there is pneumonia, you will start your antibiotics and you optimize your ventilation. This is exactly what is lung ultrasound. It's a visualization in real time what's happening with lungs. So I think the new stethoscope of the 21st century is our lung ultrasound. And I believe the handheld ones in few years' time will be in the hands of every patient. We will use it in the neonatal intensive care, pediatric intensive care, in the emergency department, even if the clinic, if you want to differentiate between who is having pneumonia and who is not. So why? It's really quick. The time you ask the radiologist to come, and then you see the image, and then probably you send it to a senior doctor on call. All this time will be much shorter if you can use lung ultrasound. It is portable, it is handy, doesn't, of course, no ionizing radiations. Just think in any sick baby how many times we do X-rays on a daily basis. And it can be repeated to follow the progress. So you've done something, and then you can do it again. In 2-3 minutes, you always get, oh, what's progress you can see with the lungs. It's visualization. It's visualizing. It's a three-dimensional organ that you visualize in real time. Easy to use technique. I believe if we start to adopt regularly the lung ultrasound, I'm pretty sure our clever nurses, in a couple of months, they will be able even to do a lung ultrasound, and they will tell you, oh, this is normal, this is atelectatic, this is RDS, this is edema of the lungs. Because it's just a pattern recognition, and repetition will always be remembered and can be perfection. So, of course, evidence, time is so short to go across the evidence, but now the evidence is already established for the use of the lung ultrasound in different, as Yasser mentioned, they use it regularly. I use it regularly in my rounds. So a lot of, and we try actually in the UK to try to spread the use nowadays. So briefly we'll talk about machine probe and just tiny bit of physics because of the time. So first of all, when you have the machine, ask the engineer if there is no lung preset to put or to get the lung settings. Okay, so we need lung settings for the best image. Number two, you use high frequency probes. High frequency probes means 10 megahertz per second or more, which is actually the linear probe, or you can use even the microlinear probe that we use it for vascular access, just to get, because of it's a small print, you can even use it in the smaller babies. So when we use the high frequency, what's high frequency? You know the TV, when you watch one channel with high definition and another one which is not, the difference in the quality of image is actually means like your probe is high frequency. The downside of the high frequency, you cannot penetrate to the deeper organ, but lungs are superficial organs, so anything high frequency will be visualized greatly. You can use any probe, but to get the best quality, use high frequency probe. Lungs are superficial. Okay, in adults, in children, and of course in newborn babies. So a bit of physics. I like here to use Yasser's actually phrase when he talks about the ultrasound and air. الهواء عدو الالتراساوند والفلويدز هو حبيب الالتراساوند وin between soft tissues هم أصدقاء الالتراساوند. So it's more of that. So actually the air الدogma اللي خلت الالتراساوند lung ultrasound يتأخر كل السنين دي compared to the other modalities or other domain of ultrasound الايديا انه ما بيعديش من الهواء. It is all reflected. لغاية ما جاء العبقري والحقيقة أنا I consider him or everybody consider him the father of the lung ultrasound دانيال ليشتنشتاين. دانيال وهو طالب كان مرة حد قال له روح ودي البيشنت دي لاسم النساء وأسونا عينه وقعت على الالتراساوند وهو بيتعمل he got fascinated وقع في غرام الالتراساوند. He cannot imagine. عارفين لما بنقول النعمة لما بنتعود عليها ما بنبقاش حاسين how great it is. Just imagine I can see what's inside you. ده الالتراساوند. And since then he became after that an intensivist. كان بيروح الحقيقة يسرق الالتراساوند ماشين من الراديولوجي ديبارتمنت thanks to the wheels ويجيبهم علشان to assess the patients in the intensive care. وهو الوحيد اللي ابتدى يشوف ايه ده there is something foggy here. Lungs can be visualized by the ultrasound. When he starts to talk about it and publish about it ما كانش فيه أي response خالص. بعد كده قرر إن هو you cannot introduce ultrasound to the people, to the doctors to understand and accept إلا بإنه يحط له some to make it palatable, to make it easy to learn, to use simple terms, to simplify it. And if you want to read something about lung and ultrasound, I recommend really his book. It's very simple, a book written with passion about lung ultrasound, Daniel Lichtenstein, and the last edition, I think, 2019. So he is the one with his colleagues, they put their work, the milestones in the story of lung ultrasound. طبعا Dr. Yasser Said has like huge amount of publications and he is the one author for a paper in 2018, very easy to read. You can go through everything like steps of ultrasound and many YouTube presentations as well. So how to do it? You just classify the chest. The beauty of the ultrasound, you don't need to turn the patient, you don't need to handle the patient. Try to leave the patient as he is or she is. If she's prone, do it when she on the back. If she is supine, do it from the front. So we divide, so we divide by, this is the anterior axillary, posterior axillary, and of course the parasternal one. So you have the front, upper and lower half, and you have the lateral, which is the lateral side. So the right side is, where is that one? The right side is, you can make it as R1, R2, and then the lateral R3, and the left side the same. You can use also R4, which is the costophrenic angle, just when you want to assess the costophrenic space and look for pleural effusion. So who should do the lung ultrasound? All of us as neonatologists, we should do it. I think with time, if we start to practice, it's really easy, and then it becomes a culture. And as I said, all the nurses, they can simply do the lung ultrasound. And usually when you ask them to learn a new thing, they get really excited and they feel valued. Oh, I can do this, okay? And the machines, like, as I said, it's one probe, linear, it's lung preset, it's not complicated. In 1-2 minutes, we can look at the full lung zones. If you need to turn the patient, or if the patient is supine, try not to turn the patient and do the lung ultrasound. Give some more time. The alveolar fluid tends to be moving with gravity. So when you can do it anytime for a newly admitted baby, as a primary tool, we can think of doing it as a primary tool, as a primary imaging tool, rather than doing X-ray. For monitoring, for any baby who deteriorated or any baby who is crashing. And when you do an intervention, you can do it also as a functional tool to assess the improvement or the changes in the lungs. So now the difficult part, like how to, learn ultrasound. So let's take it one by one. So the first of all, so we know that lung ultrasound is mainly sort of artifacts, and we need to decipher or to decode those artifacts. But there are also real parts. The real parts are the skin, the subcutaneous tissue, you have the intercostal muscles, and the ribs. So, okay. So here you have the skin, right? And you have the subcutaneous tissue. And we need to see where is the pleura, okay? So first of all, you need to, pardon, so what's this? Okay, yeah. So here, all right, yes. So here, this is the pleural line, okay? So when you have you see the skin and subcutaneous tissue, what are these? Those are the ribs, okay? The ribs. And under the ribs, there is acoustic shadow. Usually you see a black cone because, the same, it is reflected by the bone. So you see this black area between the spaces. You put the probe with the marker to the front of the patient, to the head of the patient, and you put it perpendicular to the ribs. So what you see here, what's on the this left side of the screen, you will see upper rib, okay, and this one in the middle, and then the other one is the lower rib. So just imagine that the baby's head on that side and the baby's feet on that side. Okay, so this is lung full of air. It's a beautiful lung. It's a normal lung. So the real parts, the real image is the ribs, subcutaneous tissue, and the intercostal muscle. So this is the ribs. Look at this black part, and look at the ribs. Daniel Lichtenstein is convinced that this looks like a bat, and this is خفاش, and this is the body of the bat, and those are the wings of the bat. So and it's important to know this bat sign because this is the beginning of the ultrasound. This is the beginning of when you look at the lungs, okay? So now we see, so we identify here the ribs, and you see this is the pleural line. It is thin, it's smooth, it's beautiful, it's less than 5 millimeters in thickness, okay? And this is a normal line. And it looks like this in a normal lung, okay? It can be thickened, it can be irregular, it can be disappearing, can be absent in other pathologies. What? Oh, right, okay. So now we need to think of something else called A lines. A lines is again something normal. When you have air in the lungs, there are lines parallel to the pleural line. They are called A lines. So the pattern of the lung ultrasound will be easy. It is A, B, or C. So A means that this is the base, the pleural line, it means like this is the basis of lung examination. The A line, this is fundamental horizontal artifact. The main horizontal artifact that you see, when you see, means that there is air in the lungs. So let's see how it looks like. So again, this is the pleural line. And then parallel to it, at equal distances, you will see the same line again. We call it reverberation artifacts. And this tells you, like, there are a lot of air. There is air inside the lung. This air, and I like to use here Liechtenstein actual expression, this air is either live or dead. The live means this is normal lung, and the dead means this is a pneumothorax. This is air between the two layers of the pleura. The pleural line, by the way, is just both layers, parietal and visceral. And because there is thin film of fluid in between both, this air fluid interface created that lung. When we see as one line. We don't see both lining, okay? So if the baby is breathing and no pneumothorax, it means like this line is actually moving, and we call this sign lung sliding. If the baby is having pneumothorax, it means like we have air in between the pleura, the parietal and visceral, which means we cannot see the pleura moving. And from here we have this sign which called lung sliding, okay? I don't know if you can appreciate, look, just focus on any of the area of the pleural line, and you see the line as if it moves like to and fro. So you have a baby, and the baby suddenly collapsed, suddenly crashed. And before that, he had like TTN, he was on CPAP, and then you put your probe, and then you see pleural line, and you see this nice A lines, okay? So either this is baby, if he's improving, it means like it's normalizing. If the baby is deteriorating, it probably might be a pneumothorax. In that case, you will see this sliding is absent, okay? So abolished lung sliding is a sign of pneumothorax. It can happen in other pathologies, but for now, this is if the baby is deteriorated, and this is the first sign you need to look for to rule out pneumothorax. This should be working, right? Oh, just, oh, here it is, okay. Okay, so if you focus here on the pleural line, you will see, you can see some chest movement, but the pleural line is not moving, it's not sliding, okay? So in that case, you will suspect that a baby is having pneumothorax. By the way, it is like 20 seconds diagnosis, okay? Just look at the, for anything by the ultrasound, if you want to detect motion, there is a knob called M. This is M mode. You press on that one, it will tell you if you have movement or not. So if there is movement and you are not sure if there is lung sliding or not, when you use the M mode, you will see this kind of sandy beach image. So first of all, you have the sky here, okay, and you have the sea, and then you have the sand. So you see these signs of artifacts, of movement. But if the baby is having pneumothorax, is actually silent, and then you will see just lines, and this called barcode sign. So you have a baby who had TTN, for example, and then suddenly deteriorated. You put the probe in, you see very nicely aerated lung with A lines, pleura, A lines, and then you look at the sliding. Sliding now is absent, and I will show you something else. Sometimes you see lung point, like part of the lung is moving, sliding, and the other part is absent lung sliding. And in that case, if you apply the M mode, you will see the difference. You will see a barcode sign. Okay, so here, as you can see, pleural sliding on the right side of this, my right side of the screen, and you can see like absent lung sliding on the other side. So when the M mode, it will show you that just barcode sign in the part which is moving, and when it comes to the part which is, there is some movement, you will see those Sandy Beach one. This is barcode, this is Sandy Beach, and then Sandy here, and then barcode sign. Is it clear? So any mix of air and fluid in the lung ultrasound, it will give you artifacts. So we finished the first pattern. The first pattern is A pattern. You have pleural line, parallel to it at equal distances, you have the A lines, and those A lines means that you have air inside the lung. Live air means normal lung, dead air means this air is pneumothorax, and you will see in this case absent lung sliding, and when you put your M mode, you will get the barcode sign. Okay, so just imagine, like, if you only know this from the lung ultrasound, and you can diagnose so quickly the pneumothorax in a crashing baby, how much time we can save before we get, like, normal X-ray and start to get our intervention. You can immediately, because at this time it's a matter of life and death in a matter of minutes. So this is the one on the here. This is just how it looks like normal. Okay, so you see the ribs, you see the pleural line, and those beautiful A lines, which are reverberation of that line. If this lung is sliding, this is normal lung. If not sliding, with M mode giving barcodes, so this is a pneumothorax. Then you have the other artifacts, which is the second pattern, which is B line. Just imagine, in depth, this is the lung, and there is fluid in the lung. And as we said, fluid-air interface will give you artifact. So when you have some fluid in the interstitium of the lung, you will get longitudinal lines, which are called the B lines. And this is how they look like. Okay. So you see this is the skin, subcutaneous tissue. This is just the cross-section, the ribs here. And you can see the pleura. Okay, and you can see those longitudinal lines. And sometimes when the baby is breathing, you can see some also A lines. This is considered more or less normal because you can still see clear lungs in between breath. Okay, and they are not coalescent. They are 1 and 2 in each space. And they are moving with the lung sliding. So if you see those longitudinal lines moving, it's not pneumothorax at all. Okay? They can look like that. So if you look at this one, oh, sorry, so okay. They can look like that. A lines, B lines, but more condensed. Here, more A lines, almost coalescent, almost coalescent. They can appear like this one, and in that case, when they are coalescent, you cannot identify or separate the pleura from this. Okay, why I'm saying it's important to identify how they look like. So if they are less than 3, 1 or 2, and they are moving or shimmering with the lung sliding, this can be mild interstitial edema. And if you see even in between them when the baby is breathing, you can see sometimes they are fading, and they are just 1 and 2, they can be within normal. So if this baby is having mild respiratory distress, no rush to do anything, because most likely this baby will improve. If there are more lines, like 2 lines, 3 lines, and they are more condensed, and they're reaching to the end of the screen, and then put it in the context. What this? This is a 36-weeker delivered by elective cesarean section. You think this is TTN, and then it's most likely this is TTN. But how you can differentiate between TTN and RDS? RDS is a homogeneous disease. It is everywhere. It's in all the lung zones. There will be no spare area. But with the TTN, there are areas that are spare. And usually the bases are more condensed B lines compared to the upper parts. So this is, they signify that you have, if they are mild, if they are small and not coalescent, mostly they will they will indicate that you have interstitial edema, interstitial syndrome. And the most common interstitial syndrome is the transient tachypnea of the newborn. You can have fluid overload with interstitial syndrome. You can have even PDA later on with interstitial syndrome. When it is more coalescent and more condensed, it means like you have alveolar edema. You have fluid inside the alveoli, like in case of the RDS or in case of pneumonia or meconium aspiration or even chronic lung disease. So you will tell me, so B lines in every disease. Yes, like X-ray, you just say this is white, this is black, the heart border looks like this. It's the same. It's a matter of correlation between the clinical data and the findings from the ultrasound. So if we look at this is a baby who had signs of respiratory distress born by elective cesarean section, and you can see here the pleural line, some A lines, and then longitudinal or the B lines. And if you look like this, okay, so this is not homogeneous. This is toward the basis, you see a more condensed line. So this correlates more with TTN. The same patient and went down to the basis more, so it's getting more condensed. If you look to the RDS, you will see white lung sometimes when it is so severe, B lines that you can see it everywhere in the lungs, no spared areas. And it can be so significant to the degree that you see subpleural consolidation, subpleural collapse, which is C sign then. Okay, so like in X-ray, I like this classification when you say it's black and white, or it is white. And when it is white, it can predict really, if it is homogeneous, that you need to give surfactant. So I think the most difficult part in the lung ultrasound is how to differentiate between air bronchogram and fluid bronchogram. So air bronchogram, when you see echogenic dots or streaks, subpleural, and usually you cannot identify even the pleura. The pleura is interrupted or shredded. And in that case, you will see echogenic background, and on top of that, you see more echogenic areas, which mostly static with the movement, with the breathing. And this correlates more with collapse. Okay, so here, what we see here is we went to the R4 or L4. We look at the costophrenic angle, and you see how you. So this is the right side, sorry, the left side, and you can see the diaphragm, and we can see fluid in the costophrenic angle. And as you can see, this is the lung lobe, which is collapsed, and you can see subpleural consolidation, subpleural collapse. So if you have a baby and you think this is hydrops, you don't know if you need to drain even in the delivery room, in resuscitation, or immediately after you bring the baby. It's so simple to put the probe in the right R4 or L4, and then you get the fluid, and you immediately drain, and then you can see also the progress of your management by ultrasound. Just again, when you have pneumonia, you have more of fluid bronchogram. Fluid bronchogram, you will see echogenic dots on more of hypoechoic background, because here the terminal bronchioles are fluid filled in case of pneumonia. The other one on the right is when you have more of collapse. And again, you have to correlate with the clinical condition. So I have a preterm baby, 4 weeks old, started to deteriorate. Or I have a baby who has been ventilated today, day 5, and also started to deteriorate. What you are thinking about? The first one, I would like to rule out ventilation-associated pneumonia. So if you see the image on the right side where there is hypoechoic background, and you can see those even dynamic bronchograms, which called fluid bronchograms, is correlating more of pneumonia. And of course, you have other sign. There is a nice paper from the team from Evelina, Virginie Petit, and others, and they put also full scoring to diagnose ventilation-associated pneumonia with integration of the lung ultrasound. So look at this one. This is a baby on high frequency. So a bit of hypodynamic, hypoechoic background, and you can see those streaky, echogenic dots and streaks, sorry, which signify fluid bronchogram. So quickly, lung scoring, and this image actually from one of Yasser papers. So the first one on the right, score 0, when you have A pattern. So you see the pleura and you see the A lines, clear, nice lung. So you score 0. And then the second one, when you have few B lines, they are longitudinal lines and they are moving with the sliding, and they are generally less than 3 in each space. So in that case, we'll give this a score 1. And then you go to score 2, which when the lines are coalescence, they are diffuse. And then you go to score 3, when you see subpleural collapse. So you calculate the score in 6 zones, so 3 on each side, which means your maximum score will be 18. Simply, if this is a baby who's just been admitted and he got a homogeneous disease and you have a score of 12 or more, most likely this is a severe disease. And if it is something between 7 to 12, this is a moderate disease. And from that, put it in the clinical context. You can anticipate, oh, this baby most likely will need surfactant. So no need to delay. Just do it, and the best way is to do it non-invasive. So highest score is 12, lowest score is 0 in normal lungs. All the babies in transition, they can have few lines, they can have few B lines. So other applications, we can monitor the endotracheal tube, we can check the endotracheal position, we can use it to diagnose diaphragmatic hernias. There are plenty of things that's also more evolving, so maybe in another time. So this is a 39-weeker, was given Curesurf, actually was admitted from another unit because we classified the units to level 2 and level 3, then transferred to us after 24 hours. Baby was intubated, giving surfactant, and still oxygen requirements 40%, and very hard to extubate. And the X-ray was not showing anything. Just this when the baby was in the back, and this is just one image of his back, and it signifies that really he got pneumonia, okay? So it was just very clear. I optimized the antibiotics, I kept the baby ventilated, optimized the settings, minimized the oxygen because there was element of pulmonary hypertension. I tried at all costs to avoid any kind of hyperoxia because as we know, it will induce further vasoconstriction and pulmonary vasoconstriction and increase pulmonary hypertension. So simply, lung ultrasound is you have A pattern, and the signs are you see the pleural line, you see the A lines, you see the lung sliding, or you abolished lung sliding or absent lung sliding, and you can see a lung point when there is part is moving, part is sliding, and the other side or the other part with the pneumothorax is not sliding. And the best thing here is to apply M mode. It will give you either seashore sign or it will give you just barcode, just lines. M mode, if nothing is moving, it will be just lines. And then you have the P pattern, okay, and I didn't touch much about the double lung point. At some point it was considered pathognomonic to diagnose TTN, but then it was discovered it's not anymore. Simply TTN, you will have B lines and they are not homogeneous. There are some areas spared, some areas are more coalescent compared to other parts. Usually they are darker or more coalescent towards the bases. And it can be used for many diagnostic diagnosis of interstitial syndrome, of any complication of fluid overload. Any patient will benefit of lung ultrasound. Post-operative patient you will manage. If there is fluid overload, you will know why the lung compliance is worse, what complication has happened, if developed pneumonia. So all this can be really, really diagnosed in no time. So the take-home message, we need a paradigm shift in which neonatologists have to accept a fundamental different way of thinking. Therefore, there is need to develop engaging strategies that would allow this practice transition. It's not a big deal. It's just we need to start practice. And we'll let everybody get used to see this. You are on call at home. You will get a live image of the lungs, and then you can make you know, better decision and much easier decision with avoiding radiations and handling of the patient. Thank you very much.
Thank you, Dr. Omayma, for the very interesting presentation. I'm sure it will excite a lot of questions.
Thank you very much.
The question will be in the during the panel discussion after that. At first, I would like to thank the organizing committee, Professor Hisham Awad, Professor Nihal Ragel, Professor Safa, Dr. Professor Rania for organizing